The broadcast is now starting. All attendees are in listen-only mode.
Hello, everybody. This is Allison from MICA, the Michigan Coalition Against Homelessness. Thank you for joining us today. We are going to be doing a presentation for you on infant safe sleep and other resources for families. We have two speakers with us today, Patty Kelly and Colleen Nelson, who work for DHHS as infant safe sleep consultants. And we'll be sending out some information after this broadcast via email, as well as posting this webinar on our MICA website after the fact as well, if you want to share it or view it a second time. We will be answering questions throughout, so please type them in the questions area, and I'll be sure to keep my eye on that. And then just be mindful that we are recording. So I'm going to hand it off to Patty now. Thank you.
Hi, thank
Colleen.
you for joining us. Oh, yeah, this is Colleen Nelson. I'm going to be doing the first part of the training, and then Patty will be doing the second part. And again, as you go along, if we have questions, just type them in the chat box. But thank you for joining us for this training on infant safe sleep. We're happy to be here to be able to share safe sleep information with you today. Next slide. This training has 4 objectives. First, to understand the scope of the problem of sleep-related infant deaths in Michigan. Second, to review and understand the rationale behind the 2016 American Academy of Pediatrics, or AAP, recommendations for infant sleep safety. Next, we will discuss how to help families practice infant safe sleep. And then finally, we'll provide an overview of available resources. Next slide. Before we go any further, let's review some terminology to make sure we're all on the same page. You may have heard the term sudden unexpected infant death, or SUID. These are the sudden and unexpected deaths of babies 0 to 12 months old, which the cause was not obvious before investigation. So these babies were healthy, who had no known medical conditions or concerns. So most babies who die in Michigan have a thorough investigation that's done. That can include an autopsy, family history, clinical history, and then a doll scene reenactment, which is where the investigator goes to the home with a doll and asks parents questions like, where was the baby placed for sleep? When was the baby last fed? And then where was baby found? And then from these investigations, we have learned a lot about how and why babies die in Michigan. So after this investigation is done, the death may be classified as a sleep-related infant death, which are a subset of SUIDs. And then these are infants, again, 0 to 12 months old, who die suddenly and unexpectedly, where after the investigation, it was determined that the sleep environment was likely to have contributed to the death. These are deaths that are typically ruled sudden infant death syndrome, or SIDS, SUID, suffocation, accidental suffocation and strangulation in bed, or other causes. And then from these investigations, we have learned a lot about how and why babies die in Michigan. We've learned that most of these deaths are sleep-related, and that it's not just something mysterious that happens to babies with no explanation. Suffocation is the most common cause of sleep-related infant death. Suffocation can occur due to someone or something in the infant sleep environment, like a blanket, a pillow, or a person. And then sleep-related infant deaths are the leading cause of infant death in Michigan for infants 1 to 12 months of age. If a baby dies before 1 month old, it's usually from complications due to prematurity or a congenital anomaly. Next slide. So how many babies die in Michigan from sleep-related causes? From 2010 to 2018, 1,287 Michigan babies died from sleep-related causes. So that's equivalent to roughly 58 kindergarten classrooms or 2 school buses full of children. That's the sad part. The hopeful part is that most of these deaths can be prevented. The idea that these deaths are mostly preventable is new to many people. It was once thought there was nothing that could be done to prevent these deaths, that they just happened. They were sometimes thought of as that it was God's will or fate. But we have learned a lot about sleep-related infant deaths in Michigan because of those investigations that are done, and then how to prevent them. Next slide. So that 1,287 babies translates to about every 2 to 3 days in Michigan a baby dies due to unsafe sleep. Next slide. So now we're going to look at the numbers of deaths in Michigan by year. This graph shows the number of sleep-related deaths each year in Michigan starting in 2010 through 2018. You can see along the vertical axis, you have the number of sleep-related infant deaths, and then along the horizontal axis, you have the years. As you can see, the numbers of deaths vary a bit year by year, moving up and down slightly, but there is no consistent downward progress. The average number of deaths per year is 143. And then unfortunately, the rate of sleep-related infant deaths, which is the number of deaths per 1,000 live births, has remained fairly consistent throughout these years. So those years where the numbers have gone down, the number of births also went down, so the rate has stayed pretty flat. Next slide. So this slide shows that just as there is for infant mortality in general, there's also a significant racial disparity in sleep-related infant deaths. The graph you are seeing shows the difference in rates of these deaths for different racial groups. The vertical axis is the rate of death per 1,000 live births, and the horizontal axis shows the racial groups. The first column is white-only babies, where both parents are white, and that rate is 0.8 per 1,000 live births. The second column is black-only babies, where both parents are black, and that rate is 2.8, which is more than 3.5 times greater than for white-only babies. And then that third column is the other, which includes multiracial babies, American Indian babies, Asian Pacific Islander babies, and that rate is 1.9, which is more than 2.5 times greater than white babies. So these are significant racial disparities that need to be addressed. Next slide.
We have a question before we move on, or a couple questions.
Okay.
Is there data about infants who have died in family shelters in Michigan? Any Michigan data about infant deaths with families that are experiencing homelessness?
I'm not sure if we specifically have it related to shelters. I know there's some data of if the baby dies in some place other than their own home. But we could dig a little deeper and get that information to you and see what we could find out. Patty, do you know if there's any?
No, I've not seen that pulled out specifically, but like Colleen said, we can check on that. And get back with you.
Okay.
Any other questions or just that one?
Just that one for now.
Okay, thank you. I'd also like to note that there are other disparities when it comes to these deaths. For example, we know that poverty is a major driver of poorer maternal and child health outcomes generally, regardless of family's race. In Michigan, of infants who died of sleep-related causes, 77% had publicly funded healthcare coverage, such as Medicaid. And then publicly funded healthcare coverage is often used as an indicator of lower income for families. But it's not enough to say that there's a disparity. We also need to dig deeper to better understand what could be contributed to these disparities, and that we're seeing in these deaths. So let's do that. Next slide. Social determinants of health are a powerful driver of health outcomes. There are many different definitions, but here is one. Social determinants of health are the social and economic and environmental factors that contribute to the overall health of individuals and communities. Next slide.
Ugh.
Next slide, Allison. Oh, thank you. Okay, so this slide provides a visual framework for looking at some of the areas that can be impacted in greater detail. Again, there are a lot of different graphs to show this. This is just one example from the Kaiser Family Foundation. It is in no way comprehensive, but it does show some of the areas that the social determinants of health impact. For example, we know that social inequities contribute to negative birth outcomes, including lower birth weight and preterm birth. We didn't talk about it in the data today, but when babies are born preterm or with a lower birth weight, they are also at higher risk of sleep-related infant death. And then this is just scratching the surface though, because by itself, talking about disparity and social determinants of health does not address the chain of events that produces disparity and health inequities, which include racism, both structural and individual, and other forms of oppression. There's a lot more that can be discussed around this, and hopefully you'll have an opportunity to further discussion on this. Next slide. So how much do the social determinants of health impact health outcomes? The pie chart on this slide shows the results from one analysis, and there are a lot of others that show similar results. But social and economic conditions and the environment contribute more to shaping health and thus producing health inequities than either healthcare activities or the behavior of the individual. And even when we look at the impact of behavior, structural barriers and stressors often have an influence. So we know like behavioral risk factors for sleep-related infant death are often associated with lower social economic status, where you're likely to see more stressors for families. So they may cope by smoking, or may have a harder time breastfeeding and have lower breastfeeding rates. So now that we've looked at the scope of the problem and the factors that contribute to it, we're going to change gears just a little bit to cover the safe sleep recommendations. And then these are recommendations that have been shown to reduce the risk of sleep-related infant death. We want to encourage families to follow these, but we also want you to keep in mind to keep the context, just as we discussed how the social determinants of health impact these deaths. We want to, if possible in our roles, what we can be doing upstream to kind of reduce the impact of those as well. Next slide. So everything that we do at the state of Michigan, all of the training and educational materials that we develop are based on the most recent AAP recommendations for safe infant sleep. The AAP issues updated recommendations every 5 years for a variety of healthcare topics after they complete a thorough review of any new evidence and research. The 2016 recommendations are the most recent that have been issued for infant sleep safety, and we do anticipate new guidelines coming out in the fall of this year. So on this slide, you can see that there's a link to the actual policy statement, which is the actual recommendations, and then the technical report, which is a much longer document that actually goes through the research that their recommendation is based on. So those links are there if you want to explore those further. Next slide. So we're going to go through each of these recommendations on the back to sleep, firm sleep surface, using a crib, bassinet, or pack and play, breastfeeding, and room sharing. Next slide. And then pacifier use, tummy time, avoiding overheating, smoke exposure, and substance use. Next slide. And then this final one, getting prenatal care, getting vaccinations, and then avoiding products that are inconsistent with the sleep environment. So the first one we're going to talk about is that babies should be on their back to sleep for every sleep and every caregiver. This one has remained consistent since the Back to Sleep campaign kicked off in 1994. The for every sleep part is important to stress with families because sometimes people think it's just for nighttime sleep. But we want to make sure caregivers know that it's for every sleep, day and night. The every caregiver is important too, as everyone who helps care for the baby needs to be on board with this. It is important that parents let everybody who will be taking care of baby know that they should sleep on their back. We do have in the data, babies that die in the care of someone other than the parent, such as grandma, a sibling, babysitter. So we want to make sure everyone has this information. Next slide.
Colleen, I had a clarifying question. When we're saying baby, do we just mean infants under 1 year?
Yes, that's a good question to have. So yeah, infants are considered under 1 year of age, and the recommendations from the AAP are for under 1 year of age. So why on the back? There are several reasons for this recommendation. First, babies who sleep on the back are able to get good fresh air when they're sleeping. When a baby sleeps on the tummy, like we have in the picture on this slide, he has a little pocket of air available to him that he can exhale carbon dioxide into, and where he can access oxygen to breathe in. This is the area on the slide where the little green arrow is pointing. And then as baby is sleeping, that pocket is becoming more and more full of carbon dioxide and has less and less oxygen available. Now, you as an adult, if you were sleeping on your tummy, you would get a signal from your brain saying low oxygen. And so you would turn your head and move, cough, or do something to get more oxygen. And you would likely do this in your sleep and not even know that you're moving around to do this. So some babies, unfortunately, don't get this signal. It's not well understood why not, but we do know that some babies are not fully neurologically mature when they are born, and some babies have deficiencies in their neurological functioning. So their brains just don't get that signal, and they can end up in a low oxygen situation and could potentially suffocate. Now, there's other babies that their brains do send that signal to move and get oxygen, but baby can't physically do that. So we know that babies, especially very young babies, have a very heavy head and little muscle constraint in their arms and necks. So although their brain may be telling them to move, they physically can't, and then they could end up suffocating. And the baby in this picture is on a thin sheet, but if you thought about a baby that might be sleeping on a thick blanket or something, if they were unable to get oxygen and they were on this plushy mattress or a thick blanket, it may be even harder for them to move if their brain is giving them that signal. And then this is also more risky if there's smoke exposure in the environment. Next slide. And then babies who sleep on their backs are healthier in general than babies who sleep on the tummy. They have less ear infections, less stuffy noses and fevers, and they also experience less sudden decreases in blood pressure and heart rate. And they also overheat less. One of the main ways a baby dissipates heat is through his head and face. So when baby's on his tummy, he can become more easily overheated, which is a risk factor for sleep-related infant death. That we'll talk more about that one as well. And then finally, babies who sleep on their back arouse more frequently. They are more reactive to light and sound, and they sleep less deeply. So, which for caregivers, this is something they're usually trying to avoid, right? They don't want their baby to wake up often, but this is actually protective. So if a baby arouses more frequently and easily, then if she were to get into a compromising or low oxygen situation, baby would be more likely to wake up and take a breath. So when a baby is in a very deep sleep, if he were to get into a compromising situation, for example, rolled up against a pillow or blanket, baby would be less likely that he would be able to wake up and move and get out of that situation. Next slide.
We have a question.
Okay.
Is there data about increased risk of sleep-related deaths for preemies?
Yeah, babies who are born premature are at a higher risk. I don't know off the top of my head, I don't know how much higher risk, but they are both low birth weight babies and preterm babies. So, when we're working with families that have babies that are preterm or low birth weight, that, it's really important that they're getting the safe sleep information because their baby is at higher risk. A common question we get about back sleeping is, won't my baby choke when sleeping on the back? It is important to have a simple explanation to use in this situation. One example is you could show them the picture on the slide and talk about why baby is safer on their back because of the way their body is made. So when baby is back sleeping, it protects baby's airway. When baby is on the back, the air tube is on top of the food tube. So if baby were to spit up when on their back, that spit up can't travel upward against gravity into the air tube. So instead, that fluid gets pulled by gravity back down into the food tube and back into baby's stomach. So the baby doesn't choke. When baby is on the stomach, it is actually more likely that he will choke. When on the stomach, the food tube is on top of the air tube. So if he spits up, the spit up can pool at the opening of the airway and baby could choke. So providing this explanation can be really helpful for families because this is a common concern that we see that families have. And you can also reinforce that when baby coughs, usually baby's not choking, he's just clearing their airway, which is a good thing. Another common question that comes up when we talk about back sleeping is, will my baby get a flat head if she sleeps on the back? You can let them know that tummy time can help prevent the development of a flat head. Tummy time is important for a number of reasons, not just for preventing the flat head, but it helps baby develop their neck and shoulder muscles, their arm muscles, that helps them move and meet developmental milestones. And then this picture is really like a classic picture of what tummy time should look like. We have the adult down on the floor with baby on the floor. Baby is placed on the tummy, and then as they get bigger, they'll start pushing up more and more on their arms. Next slide. Okay, thank you. So when should families do tummy time? Tummy time is an awake time that should be supervised by an adult. And usually it'll be for very short periods of time, appropriate for baby's development. And then as baby gets older, baby's going to tolerate the tummy time more and more. And tummy time should be discontinued when baby starts showing signs of being tired, can't hold his head up anymore, or if baby starts crying. And then another common concern we have is that babies don't like to sleep on their back. It's important to discuss that babies get used to what is routine for them and they thrive on familiarity. So the earlier baby is placed to sleep on the back, the more quickly baby gets used to that position. We project a lot of what we as adults like and dislike and what we as adults think is comfortable or uncomfortable for babies. We're also trying to figure out why baby's crying or upset. So if we lay baby down in the bassinet and they immediately start crying, we might think, oh, they must not like that bassinet, or they must not like back sleeping. When maybe they're actually fussing because they were all warm and cuddly and being snuggled with you, and then they're being put in that sleep environment. Or maybe their tummy is too full, or they're just having some air bubbles. Or it could also be, like we said earlier, babies don't sleep as deeply on their backs and they wake up more. So parents think this is because they don't like back sleeping, when it's really just that frequent waking that's keeping baby safer. There are a number of soothing techniques that we can use to help parents learn how to settle baby on the back. And it's helpful to teach parents these. One is you can cross baby's arms over their tummy and set your hand on top and kind of pat. That can help reduce that startle reflex that babies have when they're on their back. Also just singing and soothing and that type of thing. Now we're going to move to the next recommendation. Baby should sleep on a firm sleep surface covered with a tightly fitted sheet with no other bedding, objects, or people in the sleep area. And what does that look like? It's really just like the picture on this slide. A common question we get about this is, what is firm? What does it mean to have a firm mattress? When something is firm, the mattress will maintain its shape and it doesn't indent or conform to the shape of the infant's head when the infant's placed on it. And if it's firm, when you press your hand down on the mattress, it should spring back up immediately. And only mattresses designed for a specific product should be used. So you don't want to have someone take a pack and play mattress from a different pack and play and put it in a different one. You really want the one that came with it. And then we don't want families to add anything to the mattress, like a mattress topper. And then a fitted sheet should be used that is made for the size of the crib, and it should be tucked in tight, just like you can see on that picture. Sometimes when we show this picture to parents, they feel bad for the baby. They say she's lonely, sad, and not loved. They feel this way because they associate all the items that are usually in a crib that might make it cozy, like blankets and stuffed animals, with love. So we are working against strong social norms in our promotion of a clutter-free environment. And so we want babies sleeping in a crib, bassinet, or portable crib, or pack and play. These are all considered a safe sleep environment. And then we want to make sure that they conform with the current Consumer Product Safety Commission safety standards. Next slide. Car seats and other sitting devices like swings, bouncy seats, and inclined sleepers should not be used for routine sleep. Sleeping in a sitting device is dangerous for infants for a number of reasons, but one is the possibility of suffocation on the material, on the product or the padding. As you can see in the picture on the slide, if baby turns her head or wiggles to the side, there could easily be an airway obstruction. It also can happen if baby's head slumps down like the baby in this picture. Baby's airway is about the size of a drinking straw. So if it is bent even slightly can cause an obstruction. These devices can also be dangerous because baby can flip over in them even when the seatbelt is on. And they can also flip over even if they haven't begun rolling yet. You may have heard about the Fisher-Price Rock and Play Sleeper and other sleep products or seats that were recalled in the last couple years. And this was due to babies suffocating in them. And a lot of these were babies that rolled over and hadn't been rolling before that. So we just want to make sure that parents know that these products can be dangerous when babies are sleeping in them. Next slide. So as hard as it is, if baby falls asleep in one of these devices, he really should be moved to a sleep surface for the remainder of the sleeping time. Next slide. And then a common question we get about this is, what about babies with reflux? This is a big concern for parents, but in the updated 2016 recommendations, the AAP stated that the vast majority of infants with reflux should still be slept on their back, and that the risk of choking if slept on the tummy outweighs any possible benefit of sleeping on the tummy. In addition, we don't want parents elevating the head of the crib. Sometimes people will do this by putting rolled up blankets or towels under the mattress, or by putting blocks under the crib legs. Items under the mattress can cause a dangerous crease in the mattress that could become a suffocation hazard. Also, the angle of an elevated mattress or crib can cause baby to scooch down to the foot of the bed and can then end up in a dangerous situation. In addition, some parents and even sometimes a doctor might tell someone this, that they should have babies sleep upright in a swing or bouncy seat if they have reflux. But to the contrary, the AAP has recently stated that sleeping like this can actually aggravate the reflux due to compression on the belly. As you can see in the picture on the slide, the baby's sitting in a position where the belly is compressed right at the seat belt. And so if babies has reflux problems, that pressure can make it worse. So there are rare cases where the baby may be slept in a different position, but that baby would typically have other medical issues going on as well. And then a common concern we hear from families too is that their baby will get cold without a blanket. And we also hear parents say that they want their babies to have a blanket as a comfort item. But we know that loose blankets can be a suffocation hazard. So instead of a blanket, a wearable blanket or sleeper can be used if needed for warmth. And we also want to make sure that babies don't get too warm during sleep. As I mentioned, overheating or getting too warm can increase babies' risk of sleep-related infant death. So we want to educate families on the risks of overheating and any common signs of overheating. We do have a new resource, which I think Patty will talk about, called Don't Let Baby Get Too Warm. And it really is a nice graphic to show how to know if baby's getting too warm or not. We also don't want babies to wear hats when they're sleeping, as hats can cause baby to get too warm because baby is unable to release that heat through their head. And in addition, those hats can come off, or headbands too can slip off and become a suffocation hazards. Okay, well, that's the 2 recommendations that I'm going to talk about. I'm going to turn it over to Patty to cover the rest, and then also how to talk with families, and then cover those resources that we talked about.
Okay, thank you so much, Colleen. You gave us a great foundation there. And I just want to say thank you again, Allison, for inviting us to present today. We're really excited to be here today. Please feel free, as you have been, to be putting your questions and comments in the chat box. We hope to make this as interactive as we can in a virtual environment. So Allison, can you advance the slide, please? And we're going to continue on to the next recommendation. Okay, great. Another thing that we know will improve the health of moms and babies is breastfeeding. And we know there's a lot of general benefits of breastfeeding for moms and babies. Some examples for benefits for breastfeeding for moms are reduced risk of developing type 2 diabetes, and also reduced risk of developing ovarian and breast cancers, and also a lowered risk for high blood pressure. For babies, some of the benefits include less chance of developing asthma, obesity, and ear infections, and a much reduced risk of SIDS or sleep-related infant death. Because of that, we consider breastfeeding to be a protective activity to prevent sleep-related infant deaths. Studies have shown that breastfeeding, and it depends on exclusivity and duration, so it depends on if the baby's exclusively fed breast milk and how long, but we know that breastfeeding can reduce the risk of these deaths by up to 60%. So it really is a really significant protective factor. So we want to make sure that if families decide to breastfeed, that we support them if they choose to, and that agencies providing services to families know how to provide that support to families. And we're going to go over ways that you can do that at the conclusion of the presentation when we're in that area of what can agencies do. All right, now we're going to talk about another one of the big recommendations, and this was a new one that the AAP added with the recommendations that came out in 2016. And they recommended room sharing, and there was some confusion around what is room sharing. It's just like what's shown in the picture on the slide. Baby's in the parent's room, close to the parent's bed, but on a separate sleep surface. Like Colleen mentioned, we want the baby to be in either a crib, a bassinet, a pack and play, or a portable crib. This way, when you have it set up like this, the parent can easily reach the baby for soothing and feeding, but then when it's time, can put the baby back in his own sleep space. And you don't even really have to get up and walk down the hallway or upstairs or into another room. It just makes it really convenient. You can hear when baby starts fussing. You might even be able to just reach over and pat the baby and be able to settle them down quickly. Now, the AAP says ideally this should be done for the first year of life, but at least for the first 6 months. And our program recommends that for as long as you can to be able to do that, because it really does help to reduce the risk of death. Okay, next slide, please. The AAP does acknowledge that parents do often bring the baby into their bed for feeding and comforting, but the baby should be returned to their own sleep space when the parents are ready to return to sleep. If the parent accidentally falls asleep, the AAP recommends that the baby should be moved back to her own sleep space as soon as possible. But think about it, it can be difficult for parents to know when you're going to fall asleep, right? Think about it. When we're in bed, we're comfortable, we usually just fall asleep. It's rare that we're aware enough beforehand to know, oh, I'm about to fall asleep in a few minutes. So we really need to help parents think about the likelihood that they're going to fall asleep if they're going to bring baby into bed with them. And we're going to talk later about the importance of parents of preparing the bed for the chance that they might fall asleep and suggestions for doing that. Okay, what we really don't want is what you see on this slide, is for a sleepy parent to get up, take baby out, and then bring baby like this dad did to a couch or an armchair to settle them. These locations are the most dangerous for babies, because if the parent falls asleep, as you can see from the slide, there's a lot of stuff there that the baby can get caught up in. The baby's likely in this case to roll off the dad's chest and roll into a cushion or soft item and possibly suffocate. Babies are obligate nasal breathers, so they must breathe out of their nose. And if their nostrils get obstructed, they can't breathe. And we know, as Colleen mentioned earlier, that babies, especially very young ones, don't have the head, neck, and arm strength and the muscle coordination to be able to get out of these dangerous situations on their own in a lot of cases. They can't always just roll over into a safer position. So these situations can become very dangerous for parents. So what do we recommend that parents do if we know that this is not safe? Next slide, please. The AAP doesn't support bed sharing. There's always at least a slight risk if the baby is brought into bed. But we know, like we said, that parents do bring babies into bed with them to feed and comfort. And it's not safe for them to be moving to an armchair or couch. So what do parents do? The AAP says that to reduce the risk to the baby, if there's any chance at all that the parent will fall asleep when feeding or comforting the baby, to prepare the bed beforehand. And what does that mean? Touched on this a little bit in the previous slide. That means that we want to be removing these soft items from the bed. We want to get rid of the pillows, blankets, comforters, all the other bedding that could get in baby's way. Again, we're doing all that so that the baby won't roll up into those items and suffocate. Following the rest of the safety recommendations is also important. So we want to be using a firm mattress on our bed. Pillow tops are nice and comfortable for us, but because they're squishy and plush, they can be dangerous for babies. We want babies sleeping on the back, not overheated, no hats, like Colleen said, preferably in a sleep sack or footed sleeper. Now, when we're talking with parents about ways to prepare the bed, it may also include things like suggesting that the parent set an alarm on their phone for 15 or 20 minutes. So if a mom brings a baby into bed to nurse the baby, to set the alarm on the phone for 15 or 20 minutes so that if she does fall asleep with the baby in the bed, she's going to wake up in a short amount of time. And then after the 15 or 20 minutes, can put the baby back in his own sleep space. That is a risk reduction technique, because if you have the baby in bed a shorter amount of time, although it doesn't guarantee that an accident won't happen, it does greatly reduce the risk. And having that timer on the phone, you can have the parent just set it on vibrate. It's not going to wake the baby up, but it really does help to get the baby moved over back to their own sleep space. And that can be not just if a mom is nursing, but even if a mom or dad brings the baby into bed to comfort the baby, and they know they're going to be, the adult themselves is going to possibly get sleepy in the bed, to set that alarm on the phone so that it can wake them up and get the baby back into their own sleep space. Another technique that we suggest to parents is that talk with other adults in the home. Tell them, if you're the mom, if you ever see to move the baby to his own sleep space. I give an example in a lot of the trainings that I do, that when I was nursing my son, I would fall asleep with him in bed. That was just our regular routine. I would nurse him. I would be so tired after a long day. I'd be very comfortable and relaxed nursing him, and I would fall asleep with him. And so now he's 20 years old now. So after all these years now that I'm in this job, talking to my husband about sleep-related infant death and the risk of bed sharing, he says, well, I never was comfortable when you would fall asleep in bed with John. And I said, well, why didn't you say anything to me? Why didn't you bring this up 20 years ago? And he said, I didn't know that I could, because nursing was your thing. And it really opened up my eyes to the fact that if we want to involve and include dads in some of those infant safety behaviors and decisions, that we need to talk with them about it. We need to have them join in on the conversation and ask them, hey, you know what, if this happens, can you help me out with this? And really look at it from a team perspective. That can be really helpful, and it can really help make the environment safer for baby. Okay, next slide, please.
I have a question. It looks like somebody is asking why breastfeeding went down in popularity and now seems to be more breastfeeding.
That's a good question. I'm not sure. Originally, I think back when formula was introduced in the 40s and 50s, it was really pushed, and it was pushed in certain populations more than others. And I think people were trying to make it seem like it was a healthier choice for baby. And so I think people may have stopped breastfeeding a lot because of that. And because of that, less people were breastfeeding. So the less you see it, the less normalized it is. I think now breastfeeding is becoming more popular because we are making it a more normal type of feeding situation. People are really promoting it, nurses in hospitals, family members, other health professionals. There's also a lot more resources than there were before. In addition to just lactation consultants, there's support groups, there's peer counselors, there's warm lines and hotlines and different things you can do so that if you're having difficulty, the support's there. And a lot of times I think previously the support was lacking and it was really hard if you were having trouble because you didn't have, your mom or your sister, your aunt to help you because they themselves didn't breastfeed in a lot of cases. So I think as more people breastfeed, the better it is for parents because they can get support when they need it. And we're going to talk more about how to access some of those support things later. Any other questions, Allison, or should I keep going?
That was just the one.
Okay. All right. So on this slide, we talk about tips on how to stay awake. Sometimes parents ask us, you know what, it's so hard because every time I sit down to feed my baby or to comfort him, I fall asleep. And that's totally normal for new parents. They're exhausted. So here's some suggestions on this slide that you can talk with parents about if they want to try to stay awake so that they don't end up falling asleep with their baby. One of the big ones that we already talked about before was use that timer on the phone. You can put it on vibrate. Again, it won't disturb the baby at all. A lot of moms will put it under their leg or under their arm or something when they're nursing, and it just helps them get alert. It can be, if you set it for 15 to 20 minutes, it can be the alert to tell mom to switch which breast too. So that's also another helpful thing. Phones are also helpful in other ways, moms have told us. That not only are they using it as timers, but while they're feeding and comforting baby, they're shopping, they're scrolling their feeds, they're watching movies, they're talking to friends and families on the phone. So it can be a really helpful tool. Other ideas on here, sometimes suggesting the parent get up and walk around. That helps to stay awake. Opening a window, I don't know about now, if I would recommend this now when it's 12 degrees out or whatever it is today, but that fresh air can help keep you alert. Taking cold drink of water, those kinds of things. All right, next. Okay, very good. So I guess sort of to wrap up this discussion about preparing the bed and where do I take my baby to feed and comfort him, should you talk about bed sharing with all families? Even families that say they're not going to bed share. And we would propose yes. Discuss bed sharing with all families. I look at it the same as if I'm talking to a teen and I want to talk to them about contraception. So the teen may tell me, oh, you don't need to talk to me about this. I'm never going to have sex. And as a parent and as an educator, I would probably say something like, okay, but just in case you do, here's some things that you can do that will protect you and your partner. It's the same reasoning here. Sometimes bringing the baby into bed happens unintentionally or unplanned. We hear that all the time. The parent intended to practice safe sleep and then a bad night came along. And one way to bring it up with families is you may not plan to do this, but sometimes it happens unexpectedly. So here's some things to do that can help you reduce the risk. And again, like the APs laid out, they don't recommend it because there's no way to do it 100% safely, but those behaviors that we talked about earlier are ways that can help reduce the risk. And then you can see the quotes on this slide here. These are 3 examples that we've heard from families where bed sharing was unplanned, and the baby in each of these instances ended up passing away due to a sleep-related accident while sleeping with an adult. The first one, I laid down with my baby on the couch to watch the game, and I didn't intend to fall asleep. My baby was having a rough night, and I brought her into bed just to settle her down, and I didn't intend to fall asleep. And this one from a dad, I was up during the night trying to settle the baby down, and she was continuing to fuss, so I laid her down next to her mom in bed. And again, these were all unintended incidences where baby ended up in bed with a parent and ended up passing away due to unsafe sleep. So it's really something to Talk about with families, bring it up in the open, be planning ahead, know that parents are going to be tired, and know that even though they may have the best intentions of not bringing baby into bed with them, it sometimes happens. Okay, now we're going to transition to another recommendation, and that is to consider offering a pacifier to baby at nap time and bedtime after breastfeeding is well established. And why is this? Pacifier use has been shown to be associated with a decrease in sleep-related infant death. And researchers aren't sure exactly why that is, but two theories are that, first, the sucking that babies do with pacifiers is similar to the sucking babies do with breastfeeding. So that keeps the baby in a lighter state of sleep. So like Colleen said, they're more easily aroused. If they get into a compromising or low oxygen situation, like they're rolled up against a blanket or a pillow or something, it's more likely that they're going to wake up and be able to get themselves out of that situation. We want them to be able to wake up if they need to. The second theory is that pacifiers help to physically keep the airway open. So that may be the reason why babies who use pacifiers have a reduced risk of death. One thing with the pacifiers, we don't want to force the pacifier. Some babies don't like them, so we only want to use it if the baby wants it. But it can be a good tool for soothing the baby, and it can help reduce the risk of death. Next slide.
There are some isn't that just for babies who regularly use a pacifier, like it doesn't really lower the risk of SIDS if you just randomly give a pacifier one night?
I haven't seen any research on the actual amount of pacifier use.
Gotcha. Okay, thanks.
I don't know what they classify as a baby who used a pacifier. I don't know if it's any time at all or if it's a continued time. That'd be something interesting to look at.
That's a good point. Okay, thanks.
Mm-hmm. Yep. Okay, so what about pacifiers though? There's always safety reminders about things, right? So some safety things with pacifiers. We don't want them hung around the baby's neck or attached to the baby's clothing in any way because of the risk that it might get caught around the baby's neck, cause suffocation. We don't want them dipped in anything. I don't know if people are still doing that. Back in my day, they would dip pacifiers in different things. We don't want them dipped in anything. Now it's popular to attach the pacifier to a little blankie or a lovey or a stuffed animal. We don't want that either. And even though those are really cute, the problem with those is that then you have the baby with the pacifier in their mouth and the blanket or the stuffed animal then right up near the baby's face, which can be a suffocation hazard. So we just want to keep it simple like you see on the slide. Just want the boring little pacifier or the one that they give you at the hospital. That's what we want to be able to keep baby safe. Okay, ready for here we go. There's our next slide. You're good at this, Allison. Thank you. And this slide just wants to reiterate that we want to be promoting all of the healthy behaviors we generally do with moms and babies. We want a smoke-free environment, no alcohol or illicit drugs, and we want to be supporting moms and babies in getting health care and all the routine immunizations that'll help keep them healthy. Okay, next slide. And finally, for recommendations, we need to help parents avoid commercial products that are unsafe. And I'm going to tell you something here that you might find shocking. Not all of the products that are sold in stores or that you can buy online are safe for babies. So yes, let me say that again. Not everything that you can purchase in a store or online has been certified to be safe for babies. And honestly, I have to tell you that before I started this job, I had no idea that that was the case. I thought that if it was being sold in a store, it must have been certified by someone to be safe for babies. And I believed in the goodness of retailers and manufacturers, and I assumed that they wouldn't sell anything that was unsafe. And boy, was I wrong. It actually turns out that very few items are required to be certified to be safe to be sold in the store. Those are things like cribs and car seats and bassinets. Most products that you can buy in stores and online don't have to be certified, and many of them are unsafe. And Colleen mentioned earlier, and the one that we've heard most about in the last couple of years is the Fisher-Price Rock and Play Sleeper. And to make that one doubly worse, that one has sleeper in the name. So parents were really misled about what they could do with that product. It turns out with that product, very little product research was done in the development, and zero safety testing was done on that product. And unfortunately, as it turned out, babies died and were injured in that product. Fisher-Price ignored the complaints of consumers for a long time, took 4 or 5 years or more for the Consumer Product Safety Commission to get involved. And in the meantime, Fisher-Price sold millions of those rock and play sleepers. And all the while they knew that babies were dying in them. So that was a big wake-up call for people to really begin to think about the products that they're buying for their babies and not make assumptions that because it's sold at Bye Bye Baby or Babies R Us or even made by Fisher-Price that they're safe. We can't make those assumptions. And we have a good tool on our website that you can download and use with parents to help them learn how to evaluate the safety of the products that they use for infant sleep. And it's called, Is This Infant Safe Sleep? And it's a checklist. So how it's set up is just simple questions, and parents go through and answer the questions about the product. And if any of the answers are yes, the product should not be used for infant sleep. So you can go to our website, we'll talk about that later, and download the checklist, and then help parents learn about how to advocate for themselves and how to learn how to judge these products on their own. Now, we know that there are many products that can be used safely for infants while they're awake and supervised by an adult, like bouncy seats, swings, exercisers. Those kinds of things are fine if the baby's awake and it's supervised, and the baby should have limited time periods in those type of items. It's just we really need to be careful about products that are used for sleep.
We had a question come in back to when you were talking about pacifiers. They're asking, what about babies that will not be breastfed? Any different pacifier recommendations?
No, it's just if you're not breastfeeding, then you don't have to worry so much about that 2 to 3 week time period. Usually that's how long it takes for a baby to be what they considered well-established at breastfeeding. So if the baby's not starting out breastfeeding, you can start the pacifier earlier.
Thank you.
Yep. Okay, now I'll get off my soapbox about the commercial products because we could have a whole session on that. But just another thing on that, though, before we get off that, before we get off that slide, is just that it's a good reminder also to have parents register their products that they purchase for their children at the Consumer Product Safety Commission. We have that website listed at the end of the presentation, because there are recalls that happen all the time on products, and not just sleeping products, but on clothing, toys, furniture, things like that. And if you get on that recall list, then you'll get notified if one of the products that you have purchased has been recalled. So it's good to be aware of that and be on top of those things. Okay, now to the next slide, please. All right, so we've gone through all the recommendations about what we should and shouldn't do when we're laying a baby down for sleep. Now let's talk about why parents do what they do when it comes to baby sleep, right? Practicing safe sleep is not an easy thing to do for many, if not most parents. If that was the case, we could just give parents a little infant safe sleep brochure and they would do what we want them to do, and we wouldn't have jobs anymore because everybody would know what they should be doing with their baby. But safe sleep is hard to do. And why is that? One of the big reasons is that parents are tired, and not just tired, but flat out exhausted. As we talked about earlier, many parents start out with good intentions around safe sleep. A lot of times parents will tell us, before I left the hospital, I was set on practicing safe sleep. And then I got home and I was a few nights alone with the baby, and I was exhausted and I couldn't get the baby to sleep, and I had to do what I had to do. There's been some interesting research done recently where they actually install video cameras in people's houses, and they tape families from the time they start laying the baby down in the evening all the way through till the next morning. And they found that most parents started out following the safe sleep guidelines. They would lay the baby in the crib, all the guidelines around the crib were followed. And then as it got later and later in the night, and baby was waking up repeatedly and fussing, parents tried to get the baby back to sleep, but couldn't, and many times ended up bringing the baby in the bed with them. Even though the video camera was on, they knew what they should be doing. but they needed to get sleep themselves because they could also see the clock on the nightstand that was getting closer and closer to the time that the alarm was going to be going off in the morning. So it can be a really difficult thing for parents. Sometimes families don't practice safe sleep because they don't have a safe sleep space. They don't physically have a crib, bassinet, or pack and play for the baby. Or the place where they're staying, they don't have enough room to set it up. So if you imagine a mom who ends up staying with her sister because she got kicked out of her housing, and the sister says, okay, you and your kids can come, but I don't want anything else here. And they get the couch, but the sister's not okay with the mom setting up the pack and play. That happens too. As Colleen talked about earlier, many families tell us they want to practice safe sleep, but the baby doesn't seem to sleep well in the back. Or every time I lay my baby down, he cries up, or he starts crying. That can be a barrier for parents. Parents are also hearing lots of different opinions on this. I mean, as a parent, especially a new parent, you're getting a lot of opinions on a lot of different things. People like giving you suggestions and comments and feedback, even when you're not looking for them. But they're hearing different things. They're hearing from their sister, oh, my baby slept well in a rock and play sleeper. Sometimes they're even hearing that from healthcare professionals, recommendations that are against the guidelines. So it can be confusing for parents to sort all this out, what's true and what's not true. They're also seeing different things on social media and in movies and other things that conflict with the guidelines. And finally, cultural and family practices play into this as well. There are a lot of things that we do with babies that stem from cultural practices. Okay, how much we bundle up babies, covering their faces, if we want to keep them physically close. A lot of these things are related to deeply rooted family and cultural traditions. So it's no surprise that there are cultural things related to sleep in babies. So this slide is showing us, how do we talk to families about this then? There's a lot involved in it. This old style that you see on this slide of the professional just giving the client information, a one-way ticket. Does that really work? Well, no. And why is that? One of the reasons is that it doesn't give the family, or here you see the client on the other hand in the purple shirt, any chance to explain the difficulty she's having with it, any challenges, any questions. It's using that cookie cutter approach where you provide everyone the same education in the same manner and you expect the same outcomes. And that's just not realistic. This method also tends to shut the client down because a lot of times she feels that if she has any questions or she's had trouble following the guidelines in the past, that she's a bad parent or there's something wrong with her. So this really doesn't give us the effect that we want. So what do we want? Next slide. What we want is more of a conversational approach, which is what we try to depict in this slide. So we want this dialogue, a back and forth. You can see in the other slide there was one arrow, now there's two arrows going both ways. This is a conversation, or this should be a conversation between two equals. Now the professional, she may have some knowledge about the topic and awareness of resources and knowledge of what's available out there for the client. So we might consider her a content expert. But the client, she's the context expert. She's the one who's an expert on her life, her family situation, her values, and her baby. She knows how to survive and manage in the environment that she's in. And she's the one who's going to eventually have to apply the safe sleep guidelines to her life, in her circumstances, and in her environment around her family and her friends. So we want to have this safe space where families trust us and feel comfortable sharing with us what's really going on, and then we can really have a genuine conversation about this. Next slide. So what are some things that we can do to help generate and create that safe space? One thing that can help is to ask open-ended questions. And those are simply the questions that give you more than a yes or no answer. So instead of asking, do you have a crib or pack and play, which would simply give you a yes or a no, you could ask a question like, well, how did things go with your baby sleeping last night? Or tell me what you know about safe sleep. In this way, we're getting more than that yes or no. Really helps to open up the conversation. And it's encouraging parents to share what's really going on with them, their challenges, what they're worried about, what their concerns are. And that way we can really have some conversation that will lead to helping the family move forward. Providing the safe sleep education is important. That's why we went through all that first part of the presentation. And families have told us they really want to know the whys behind the guidelines. They want to know why we recommend back sleeping, why we recommend pacifiers, why we recommend breastfeeding. So it helps them understand why we're asking them to do the things that we are. Think about it. When you go to the doctor and he suggests that you do something, we want to know why, because it really helps to give us motivation to make that change. And it also helps families explain to other family members and friends who may question them about some of the guidelines. And this can be easy to do. It doesn't have to be complicated. So when you're talking with the family about safe sleep, just something like your baby should sleep on the back because it keeps the airway protected or help prevent choking. Or your baby should sleep in a crib or pack and play because. And then simple wording, simple language on that. We have a lot of materials on our website that can help provide the language to give families the background on the guidelines. And if you don't feel comfortable providing the whys behind the guidelines yourself, you can find partners in your community who can provide the education on the guidelines. And we're going to talk a little bit later about how to find those partners. All right, next slide. Additional things you can do that help build that relationship with families: validate parents' experience and feelings. You know, simply telling them, yes, this is hard. I know, going without sleep is hard. Practicing safe sleep is hard. Be with them in their struggles around that. Let them share it and validate it. And follow it up with an acknowledgement of their strength. I know that this is hard, but you've stuck with it through so much. I'm confident you can do this, and I'll be here to help you. A lot of the parents we work with don't get a lot, if any, positives from anywhere. So you providing that positive boost can really be a support to them. Everyone's always pointing out their negatives. It can be a huge boost to the parent to point out a positive. Even simple things. I see how your baby smiles, ain't you? You're doing a great job keeping up with your baby's appointments. Look at how active your baby is. Look at him looking at you. He really responds to you well. Those kinds of statements can really help to boost parents' self-confidence. And finally, what's mentioned on the slide too, learning about the family's cultural and family traditions. Adopting that we call it the both and approach. How can you both keep the baby safe and honor the cultural traditions of the family? That's not easy to do. That requires us to look at ourselves and to be open about thinking outside the box and ways that we can help support families. Okay, now the next slide. Now we're going to move sort of into the resource part of the presentation. So now that you've learned about safe sleep, what can you do? First and foremost, first step is to make sure that a safe sleep environment is available to the family. Families can't practice safe sleep if they don't have the crib, bassinet, or pack and play to use for a safe sleep space. Also, if you work in an agency where infants stay, and a shelter that has families and infants or transitional housing, do you provide a crib, bassinet, or pack and play for the family to use for the infant? If you work with families directly, do you refer them to resources to obtain a safe sleep space? And we have a good tool on our website, and I put some snips up here to help you work through it. Our website is michigan.gov/safesleep, and you'll have access to this PowerPoint, so you don't have to worry about writing that down. But when you go to our website, you'll see on the homepage 3 dark blue buttons, which is similar to what you see on your screen here. One says Safe Sleep Resources by County. And if you click on that button, this map that you see on the slide of Michigan by county will come up. Then you click the county that you're in and see if there's an agency in your county that can assist with the pack and play. Not every resource is listed here, so you may know of your own resources in the community, or if you contact the agencies that are listed for your county and nobody has anything, because a lot of this is dependent on funding. So sometimes they run out of funding for these. But if you're having difficulty finding an agency through this method, you can always try contacting the local health department or the local DHHS office. A lot of times they'll have those available. There also may be smaller community agencies in your area, like local churches or baby pantries that distribute those items. But it's important to have, I mean, as you all know, you work with families who are experiencing challenges, to have your resources available so that you can assist families in finding that most basic first step, which is the crib or pack and play. Next slide.
We had a comment from a couple slides before. It says more a comment than a question. It's important to have honest conversations about harm reduction when it comes to parents and caregivers, substance use, and baby sleep. The adult may end up falling asleep with baby because they just did a dope shot, so we need to be able to address that non-judgmentally, help plan with them for that. Okay, let's say you get up late at night, what will be your plan?
Yeah, great point. Great point. Yeah, we definitely want to be doing that. So having parents come up with some kind of safety plan. If you're not going to be able to take care of your baby for whatever reason, then how can we make sure that your baby's going to be taken care of during this time when you may not be able to yourself? So that's a really good point. Thank you for bringing that up. Yeah.
That's it.
All right, very good. Okay, so another way we can help families by supporting breastfeeding. And again, this is two-tiered. So first, we want to help families that you serve by supporting families and encouraging them. And second, make sure your agency is supportive of breastfeeding. And we're going to talk about that second. First, let's talk about the families. What can we do to help support families who choose to breastfeed? WIC is a great resource. Not only do moms who breastfeed get additional food, but there are peer counselors for breastfeeding that can work with a mom one-on-one and support them every step along the way. WIC recently added a breastfeeding warm line, and I put the warm line number here that can help parents get additional support. And another good resource is the Michigan Breastfeeding Network. They do a lot to support and promote breastfeeding. And one really good resource that they have on their website is a list of local coalitions and support groups that parents can attend. And a lot of this work has been transitioned to being done virtually. So even with COVID, we're still able to support families through this. Okay, next slide. Now for agencies, think about, does your agency support breastfeeding? And these are just some of the questions that we encourage agencies to think about. Do you offer a space for moms to nurse or pump that is private, clean, comfortable? Does it have access to a refrigerator if mom needs to store milk? Does it have access to an outlet if she needs to use a pump? Does she have access to a sink to wash her hands and clean her supplies? And this is important. Is this space not a bathroom, a storage closet, or a furnace room? We want to be supporting nursing moms, not in the bathroom, storage closet, or furnace room. In addition to those nuts and bolts, is your agency promoting breastfeeding in general? Are you encouraging pregnant moms to think about breastfeeding and connecting them with resources? Do you offer educational sessions around breastfeeding? Do you post positive images of moms breastfeeding? And I think sometimes people have a thought that maybe some moms have too much going on to bring up breastfeeding. And I think we really need to move away from that type of thinking. A lot of times breastfeeding can actually be easier than bottle feeding for moms, and it's cheaper, and the physical, emotional, and mental health benefits for both moms and babies can be so important. So we need to make sure that we're not making it available and as an option for people to choose. And there's a lot of things you can do as agencies to do that. Part of what Allison's going to provide you after this is not only the PowerPoint, but also a list of resources for families in Michigan. And there are a lot of resources listed around breastfeeding that can be helpful. Okay, so now on this slide, we're seeing our next suggestion for helping families is to refer them to home visiting programs. And yes, most home visiting programs will visit moms in shelters, motels, or temporary housing situations. Get familiar with the home visiting agencies in your community so that you can feel comfortable making those referrals. And most home visits are, like I said, even as similar with the breastfeeding support, these are being done virtually now too, so that families still have access during COVID. And they can help connect moms to a variety of different resources, help them work through challenges around safe sleep and feeding and sleeping with newborns. So a great place to start to find these home visiting programs is in a website called myhomevisiting.com, which is listed on the slide. And then you simply click on the button called Find a Home Visiting Program, and you enter the zip code. And on the slide, I entered 48205 as an example. And then next slide. What comes up will be, as you see, a listing of agencies that serve people in that zip code. And again, I encourage you to get to know these agencies, get familiar with them, get comfortable with the staff there. They can be a big support to the families in your programs that are experiencing some challenges around pregnancy, maternal health, and infant health. All right, next slide, please. Another way that we can help support families is to help them access immunizations. And they can do that either through their own healthcare provider or through the local health department. And we know that this is an area that COVID has greatly impacted. Kids are behind in their immunizations. And families will need help in figuring out where they're at with immunizations and how people can safely access them. So as was on the previous slide, using immunization schedules like those that are really clear, very visual, and sitting down with the family and helping them figure out where they're at and how they can get to where they need to be can be really helpful. Parents can feel really overwhelmed with immunizations. Okay, so this slide, we want to be supporting families with smoking cessation and reduction. It's very important. The number on here is a number to the Michigan Tobacco Quit line, which is not just for moms, but that's to all Michiganders. There is a special program that they have for pregnant and postpartum women that gives incentives for them to participate. I think now they give them $10 for each prenatal call and $20 for postpartum calls up to a certain limit. So that just helps to provide an extra motivation for moms to participate. I also recommend, there are some really good resources at smokefree.gov. There's a button called Smoke-Free Testing Programs. And if you click on that, there's two really good resources, one called Daily Challenges and one called Practice Quit. And these are really nice ways to introduce clients to the idea of quitting and help build up their skills so they can be successful when they do decide to quit. Finally, there's a program offered in many areas in Michigan, and it's called SCRIPT. It stands for Smoking Cessation and Reduction in Pregnancy Treatment Program. And this is an evidence-based program that's specifically geared to pregnant and postpartum women that helps them follow a program to reduce their smoking and then quit. Comes with a workbook that helps women learn coping techniques to use instead of smoking, really good practical suggestions for stress management. Unfortunately, I don't have a centralized number to call for that. If you want to learn if there are SCRIPT programs in your area, I would suggest that you contact me. I'm familiar with a lot of those programs and help get you connected. Okay, here we go, very good. Now we're listing some of the resources. Kelly mentioned this earlier. Our program has a lot of educational materials that we've developed. This is just a sampling of the topics. You can either order these for free or download them from our website. Most of them are available in English, Spanish, and Arabic. We also have some bulletin board kits that can be put up at your agency. And they're basically a kit where everything's provided, the signs, the pictures, the wording. And it's nice if you have some areas that you want to put up something educational for families to look at. And then I'll show you where you can get these resources on the next slide. Here, oops. Do we have a slide that lists our website?
Yep, sorry, I hit it twice because I was looking at
okay.
the questions. So I'll redo the question while I have to go back in for that.
Okay, no problem.
So this person is wondering for common spaces like soup kitchens and warming shelters where there may not be private spaces available. Should staff also support breastfeeding parents and educating other participants to defend the parent if they get heckled for participating in breastfeeding?
Well, yes, I would say yes. If you're in that type of setting and you're looking for ways on how to support breastfeeding, please reach out to me and Colleen, and we can try to help work with you on some ideas around that. it's really important to be able to support the breastfeeding. A baby who's in that situation could benefit even, the benefit will be very great for them if the mom's able to continue breastfeeding. So we really do want to support it. I know it can be challenging. Please reach out to us. We have some contacts at the state as well for additional breastfeeding support. So we'd love to be able to work with you on ways to help provide those spaces where families feel comfortable and safe breastfeeding. Thank you for finding the slide, Allison. Good. Yeah. Our website is listed here on the top, michigan.gov/safesleep, so you can explore on there. All of our educational materials are listed on there and they're available for download. There's also a number of other different resources like videos for parents, online training for staff, a number of different things for you to explore for resources. The second website listed here is the Mdhhs Clearinghouse website, and that is at healthymichigan.com. And that's a site where you can go on and not just safe sleep, but there's a number of other different topics on there too, like immunizations, tobacco, different things you can, educational items that you can order for free and have shipped to you for free that you can distribute to clients. So I would encourage checking both of those out. Next slide, please. Okay, and then these are just some of the other resources that we offer. As I mentioned on our website, there are some online trainings. I know some of you have to maintain some continuing education credits for different professions like nursing and social work and health education. So we do offer continuing education with a lot of those trainings, so you should check that out. We also have webinars quarterly on different topics, and on the slide are some of the different topics we've done in the past, and most of these are available on our website as a recording if you're interested in any of those. Next slide, please. The best way to stay up to date on what we offer when we have new educational materials out or when there's going to be a webinar or a training is to join our Infant Safe Sleep email listserv. And you can do it either at this link or by way of the link on our website. And we don't bombard you with emails. We keep it maybe to once a week or once every 2 weeks. But it's always a good resource information on, like I said, if there's a webinar coming up or new data or new resources. So I encourage you to get in the loop by signing up for that listserv. Next slide, please. We're almost done here. Thank you guys for hanging in there with me. These are some national resources that you can explore. Again, the Consumer Product Safety Commission website is on there. You can encourage clients and yourself also to enroll on for recall information on products. And then just some other good resources that you might want to check out around safe sleep. Okay, next slide. And then this is Colleen and myself. And please feel free to reach out to us. As I mentioned before, we're here to be a resource to you for help with safe sleep and infant health and breastfeeding. So please reach out if there are ways that you think that we can assist you. We are, this fiscal year, we are wanting to do some pilot projects with agencies that work with families to try to help better incorporate infant safe sleep into agency practices and protocols. And things like, you know, does your agency have a safe sleep policy, or do you need to revise your safe sleep policy, or some of the nitty-gritty details around how do we practice safe sleep on a daily basis here, how do we train staff, those kinds of things. If you're interested in maybe getting your agency involved in some of these pilot projects, again, reach out to Colleen or myself. We're here to be a resource for you, and we want to help you be able to serve your families. All right, I believe that's the last slide.
It is. Thank you so much. If you have any other questions or comments, now is the time to put them into the chat. We want to thank everyone for sticking in here the whole webinar. Nobody dropped off early, doesn't look like, so thanks for that. And as a reminder, I'll be sending out the PowerPoint along with the materials that Colleen and Patty spoke about in an email after this. You will also receive a survey, which would be really helpful if you could fill that out so we know if we're giving you the kind of content that is helpful to you. And you'll receive a certificate, which is not for continuing education credits, but just shows that you participated today. And it doesn't look like there's any other questions. So thank you so much for your time and have a great day.
Thank you, everyone. Thank you, Allison.
Yeah.